Hello, I'm Dr. Hashem Alwadie. Talk today about management of diabetes in pregnancy. Diabetes in pregnancy, the prevalence of diabetes, as we know in pregnancy, has been increasing in the United States, also parallel with the worldwide epidemic of obesity. Not only is the prevalence of type 1 and type 2 diabetes increasing in the women of reproductive age, but there's also a dramatic increase in the reported rates of GDM. Diabetes confers to significantly greater maternal and fetal risk, largely related to the degree of hyperglycemia, but also related to chronic complications and comorbidities of diabetes. So diabetes in pregnancy may increase the risk of obesity, hypertension, and type 2 diabetes in offspring later in life. According to World Health Organization and VIGO, hyperglycemia in pregnancy can be classified as either pre-gestational diabetes or gestational diabetes or diabetes in pregnancy. So pre-gestational diabetes include women with known case of type 1 or type 2 or rare form of diabetes before pregnancy. GDM may occur any time during antenatal period and is not expected to persist postpartum. And diabetes in pregnancy applies to pregnant women with hyperglycemia that were first diagnosed during pregnancy and met to WHO criteria of diabetes in the non-pregnant state. And diabetes in pregnancy is best detected during the first trimester. It has been estimated that most 75% to 90% cases of hyperglycemia in pregnancy are GDM. So in this slide, the overt symptoms of hyperglycemia during pregnancy are rare and may be difficult to distinguish from normal pregnancy symptoms. As a result, an oral GTT is recommended for screening of GDM for all women between the 24th and 28th week of pregnancy. But for high-risk women, screening should be conducted earlier in pregnancy. The diagnostic criteria for GDM vary and remain controversial, complicating the comparisons of research data. There has been a move towards the diagnostic criteria advocated by International Association of Diabetes and Pregnancy Study Groups and WHO, and this has resulted in general increase in the overall prevalence of GDM. So this slide shows, diagnostic criteria and studies used for estimating hyperglycemia in pregnancy. Here are the many criteria. We'll select some like this one, ADA and WHO and FIGO. Which, fasting blood sugar, if it's 92 milligram per deciliter, so we can say this patient have GDM. And 1 hour post OGTT, if it is 180 and above, so we can label patient as also GDM. And 2 hours, 153 milligram per deciliter. So one of them, if it is high and positive, we can diagnose our patient as GDM. So we'll talk about preconception and counseling. Recommendations: starting at puberty and continuing in all women with diabetes and reproductive potential. Preconception and counseling should be incorporated into routine diabetes care. Family planning should be discussed and effective contraception. with consideration of long-acting reversible contraception should be prescribed and used until a woman's treatment regime and A1C are optimized for pregnancy. So preconception counseling should address the importance of achieving glucose level as close to normal as safely possible. Ideally, HbA1c less than 6.5% to reduce the risk of congenital anomalies, preeclampsia and macrosomia, and preterm birth and other complications. So all women of childbearing age with diabetes should be informed about the importance of achieving maintaining as near glycemia as safely possible prior to conception and throughout pregnancy. Observational studies shows an increased risk of diabetic embryopathy, especially an encephalopathy, encephaly, microcephaly and CHD, renal anomalies and caudal regression, directly proportional to elevation in A1C during the first 10 weeks of pregnancy. Although observational studies are confounded by the association between elevated preconceptional A1C and other poor self-care behavior, the quantity and consistency of data are convincing and support the recommendation to optimize glycemia prior to conception. Given that organogenesis occurs primarily at 5 to 8 weeks of gestation, with an A1C less than 6.5% being associated with lowest risk of congenital anomalies and preeclampsia and preterm birth. There are opportunities to reduce all women's and adolescents of reproductive age with diabetes about the risk of unplanned pregnancies and about improving maternal and fetal outcomes with pregnancy planning. So pregnancy planning is very important for all diabetes ladies. Effective preconception counseling could avert substantial health and associated cost burdens in offspring. So on the slide, we show family planning should be discussed, including the benefits of long-acting reversible contraception, and effective contraception should be prescribed and used until a woman is prepared and ready to become pregnant. To minimize the occurrence of complication beginning at the onset of puberty or at diagnosis, all girls and women with diabetes of childbearing potential should receive education about the risk of malformation and the use of effective contraception.